All right, good morning, everyone, and welcome to Neurology Grand Rounds. It is my pleasure to introduce one of our own this morning, Khushboo. So, Dr. Verma completed her medical degree and internship at the Ravindranath Tagore Medical College in India. She went on to serve as an observing physician at the Department of Pediatrics in Leuven, Belgium, before joining us at UT Austin Dell Medical School for her residency in pediatric neurology. Dr. Verma's clinical interests include atypical variants of Alzheimer's disease and frontotemporal dementia. And her research, some of her research, has focused on imaging predictors of dementia in the early stages, among many other projects. After graduation, Dr. Verma will complete her fellowship in behavioral neurology at Stanford University. Today, Dr. Verma will be discussing disease-modifying therapies in Alzheimer's disease. So please join me in welcoming Dr. Verma.
Good morning, Dr. Reyes. Thank you for that kind introduction. I'll get started. And these are my disclosures. I have no disclosures. So we'll get started right away. The topic of my talk is disease-modifying therapy, therapies in Alzheimer's disease. And primarily, we're still questioning there yet. And so the answer to this question is a single word. And you may say, well, if it's a single word, why should we utilize the next 45 minutes to still do this question? And the reason is, if we do not know why we are not there yet, how will we get there yet? So in addition to that, the drug approval for Alzheimer's disease, especially disease-modifying therapies, has been a great controversy, and it's pertinent in the current times. If you would think that there was a drug that was approved 20 years after the last drug, it should have been received with open arms, both by patients, physicians, FDA, everyone. But that did not happen. There were a lot of members from advisory committee of FDA who resigned after aducanumab was approved. There were questions about the way the drug was approved. In addition, EU, other Western countries such as Canada did not approve the drug, so it was only approved in the US. One of the FDA statistician commented that the way the data analysis was done for this drug was as if shots were fired and then targets were drawn around it. Even more recently, the drug has been a part of controversy. So just 2 weeks ago, this medication was withdrawn from the market, which is very strange for all the efforts it took to approve the drug. So we'll get started with our objectives. And these objectives are all designed to answer the question, are we there yet? So the third objective is appraising the contemporary disease-modifying therapies. And the first and second objective are designed to get us there so that we can do the thought experiment together. So we'll get started with reviewing the molecular pathophysiology of Alzheimer's disease. So Alzheimer's disease, as you know, is characterized by deposition of extracellular plaques outside the cells and intracellular tangles inside the cells. And these two things are the pathological hallmark of Alzheimer's disease. But the story starts with amyloid precursor protein. And this is a protein that we all have in our body and brains, and it is an essential protein. It has a multitude of neuroprotective effects in our brain. And so the question arises that something that was so useful for us, how come that is making a neurotoxic product that is accumulating outside the cells? So in the next few slides, we'll pursue that together. How does this transition happen from amyloid precursor protein to extracellular plaques? So when we look at the structure of amyloid precursor protein, it is a transmembrane protein. So that is to say, this is the extracellular space, this is the intracellular space. And since it is transmembrane, it's spanning across a bilipid membrane layer. And as you can see, this part of the protein that's in between the two lipid layers is the most hydrophobic part. It is made up of 40 amino acids. And so whenever we degrade this product, if for some reason this part is intact, it will result in accumulation of the degradation products. And when amyloid, the 40 amino acid chain accumulates, we will call it as amyloid beta 40 monomer, and then it forms the oligomer, and then from there on, it forms the plaques. Now, what happens if you cut the protein right here, so 2 amino acids extra in addition to the 40 from this transmembrane region? Well, that results into even more stickier component. This is even more hydrophobic as compared to the amyloid beta monomer. So this being said, let's now look at how it's degraded in our brain cells. So again, the same thing, extracellular space here, intracellular space here. Our amyloid precursor protein is right in the bilipid membrane layer. Alpha secretase is an enzyme that we all have. It comes and it snips it right here. So it breaks the most hydrophobic part into 2 small pieces. What happens next is gamma secretase comes and it snips it right there. And as a result, we don't have any plaque formation because the most hydrophobic part has been broken during the breakdown process. So we all have, sorry, my mouse is misbehaving a little bit. Okay. Excuse me. Okay, I'll use my hands. So what happens in the amylogenic pathway? Instead of the alpha secretase coming first, we have beta secretase that comes first. So what it does is it snips the protein at the top portion, and that leaves the most hydrophobic part intact. And the gamma secretase does its job, and it kind of snips the bottom part. And as a result, we have this most hydrophobic part that is intact, and it starts accumulating extracellularly and forms plaques. So the major difference between the normal pathway of this breakdown process is that instead of alpha secretase, beta secretase comes first. As we grow older, we have a beta secretase that builds up in our body, and alpha secretase quantity decreases. And that's why age is a strong risk factor for Alzheimer's disease. There are a few mutations that also play a strong role in the pathogenesis. So the first is trisomy 21. This is the chromosome that encodes for the amyloid precursor protein. So we have 3 copies of chromosome 21. As a result, we have a larger amount of amyloid precursor protein being formed. And as a result, there is a larger chance of this protein going to the beta secretase first pathway. The other thing that can happen is mutations in the amyloid precursor protein itself, which make it more predisposed to go through the beta secretase pathway. And then last but not the least, we have mutations presenilin 1 and presenilin 2, which will shift the snipping activity of the enzyme a little lower to make it form amyloid beta 42 monomers. And as you remember, these are the ones that are going to accumulate in a larger quantity, and they'll also accumulate confluently in the brain, the reason being they're more hydrophobic. Throughout the talk, we will use this timeline graph to see how the disease proceeds and what are the biomarkers involved. So bottom here is, our y-axis is the biomarker magnitude, and the x-axis is our disease states. And right here is normal, and everything above this is abnormal for biomarkers. And so we'll look at the different biomarkers. So first to come is beta amyloid. Now I want you to pay attention to the detection threshold. This is the sensitivity limitation with the biomarker detection techniques we have. So in case of beta amyloid, for this curve, I'm using the data for PET beta amyloid imaging. And so this basically means that the amyloid is built up for a while until it's detected by the PET beta imaging, and that's because we don't have 100% sensitivity. That is again to say that even though this part is abnormal, this buildup of beta amyloid is abnormal, we do have some limitation until when we can detect it in our bodies. Moving on to tau pathogenesis. So, tau is also a normal protein that we all have in our bodies. And this is something that is living mostly intracellularly. And the role of tau is to stabilize the cytoskeleton. So, if you were to imagine cytoskeleton is small little beads that are strung together, tau is that cellophane tape that makes them stable inside the cell. So, what happens when plaques come into picture? This results in activation of kinases, and intracellularly, these kinases go to these tau. The tau are the pink structures here, and they start phosphorylating the tau. What happens as a result? So the tau will disintegrate from these cytoskeleton structures, and because of that, the cytoskeleton starts disintegrating and it breaks down. In addition, the tau itself forms paired helical structures in the cytoskeleton. So as a result, your cytoskeleton of the neuron will have an extensive accumulation of tau tangles. In addition, there will also be disintegration of cytoskeleton, which is primarily present in the axon, and this will result in cell death. In addition to just this process causing cell death, there's also a synergism pathway, which was very interesting when I was doing my own research to find that tau itself also drives further accumulation of amyloid protein. And I'll look into this further. In addition, as you can imagine, if you are having cell death, you will cause volumetric loss in the brain and you will cause neurodegeneration. That is why the neurodegeneration arm is very closely correlated with tau pathology. So here we are back at our timeline graph, and we see amyloid comes first and tau follows afterwards. And the volumetric loss closely follows after the tau has been deposited in the brain. But synaptic function actually comes after amyloid and before tau. And that makes you think, does amyloid have any role in synaptic dysfunction? So if you can imagine, amyloid is sitting outside the cells, and so there will be some physical disruption in synaptic transmission just by the extracellular presence of amyloid plaques. In addition, it also causes neuroinflammation. So if there is a toxic protein sitting outside brain cells, our resting immunity, including microglia and astrocytes, are not happy about it. So once they detect it, within a few hours, the microglia gets activated, it gets swollen, it starts producing cytokines, other inflammatory molecules. And another visualization to look at it is, here is our plaque and all the microglia has come, surrounded it. Now they're reacting. They're starting the inflammatory cascade. Our astrocyte is here. And the whole idea here is that we want to remove this plaque. We want to digest this plaque. Neurons in this pathway are unfortunately innocent bystanders. So they are here, unfortunately, they see all the inflammatory cascades, and that is how we lose synaptic connection. So both by the fact that there is physically a lot of toxic material sitting outside, and chemically by inflammatory cytokines, our synapses are lost. And so that makes sense. Amyloid comes first, synaptic dysfunction comes next, and then tau and volumetric loss follow shortly after. So we've talked about a lot of mutations a little while ago, and we haven't talked about ApoE4. Why is the reason I bring ApoE4 in the middle of while we were talking about neuroinflammation? The reason being, ApoE4 has a very strong role in playing, in causing a robust neuroinflammatory response to the presence of beta amyloid in the brain. So the mutations that we reviewed earlier account only for 5% of Alzheimer's that we see in the population. So that is a very small part of the pathophysiology. And if you want to understand the majority of pathophysiology, you have to look at what ApoE4 does. So this is a graph that talks about the genetic profile of Alzheimer's disease. And on the y-axis, you see the different genes that can cause Alzheimer's disease, and the risk of the gene causing Alzheimer's disease goes higher as you go up the y-axis. The x-axis is describing the frequency of the genes in the population. So you see all the genes that we went over are here that have a high propensity to cause Alzheimer's disease, but they're really rare in the population, about 1 to 5%. And we have a few genes that are very common, but their risk of causing Alzheimer's disease is low. So we have a happy medium or an unhappy medium right here, where they have a medium risk of causing Alzheimer's disease, and they are pretty frequent in the population. Out of ApoE4 and TREM2, we will focus on ApoE4 today. So what is ApoE? ApoE stands for apolipoprotein, and we have different isoforms of the ApoE gene. So, and they're different isoforms because of the positions because of the different amino acids at these two positions. And what I like to use as an analogy is when you go to pick an ice cream, you can pick any flavor, and that is what happens with ApoE4. The only difference is you have no choice in picking whichever ApoE4, whichever ApoE gene that you get. So you can get the neutral ApoE3 that most of us have. You can have the neuroprotective ApoE2 that a few lucky ones of us have, or you can have the ApoE4, which is the isoform that's having a high risk factor for causing Alzheimer's disease. So this is the frequency of ApoE isoforms in the population. So in this talk, about 80% of the people will have ApoE3, that is the neutral one, and a few lucky ones of us will have ApoE2, and a few unlucky ones of us will have ApoE4. What is really interesting to note that this is the frequency of this isoforms of these ApoE genes in the population, but in the general population. But in Alzheimer's, the ApoE4 frequency is 50%. So it goes up from 14 to 50% in Alzheimer's disease population. This indicates that this is a very strong risk factor for causing Alzheimer's disease. So we were in our neuroinflammation section, so we'll go back to neuroinflammation, and we will see what ApoE does to the neuroinflammation pathway. So what it causes is a very robust inflammation reaction, and that results in subsequently higher deposition of beta amyloid in the brain, and it is really essential for the very initial laying down of beta amyloid in the brain. And how does that translate in terms of our timeline? So if we were going to develop Alzheimer's with our neutral ApoE3 isoform, we will be here. But what happens if you have ApoE4 instead of ApoE3? Well, the deposition starts earlier, and you will develop the disease symptoms about 10 to 20 years earlier than if you had E3 isoform. What if you had E2? Well, in that case, you're going to develop the disease pathology and the biomarkers 10 to 20 years later than the E3 isoform. So the primary takeaway from our very first objective is that we have multiple abnormal proteins that accumulate in the brain, and they result in loss of synapse, they result in the loss of cell. And if we wanted to do something about treating the condition, we have to target beta amyloid. This is the first step. This is where we have to attack. There are tau therapies, but this happens after synaptic dysfunction, and you already have volumetric loss. So it is strange that there are tau therapies. I would place my bet on beta amyloid therapies, because that's the first thing that goes wrong in your brain. So we have reviewed the molecular pathophysiology of Alzheimer's disease. Let's now discuss the biological construct for diagnosing Alzheimer's disease. The biological definition of Alzheimer's disease comes from this 2018 paper. This was a research framework that was given. And before we review what is the biological definition of Alzheimer's disease, let's take a step back and kind of go over how we diagnose Alzheimer's disease. So we look at a cognitive dysfunction and we look at a particular pattern of amenestic insidious complaints. So you should have slow, long-standing complaints of predominantly memory issues. So we look at a syndrome and a phenotypic presentation. That's how we diagnose Alzheimer's disease. And we say, well, probably or possibly you have Alzheimer's disease. But what happens in the biological definition is we look at the biomarkers and not the phenotypic presentation, because we know that the phenotypic presentation only indicates the location in the brain. It's not talking about the pathophysiology. And once we are talking about disease-modifying therapies, once we are talking about targeting biomarkers, then we need to have a shift in our thinking from that clinical diagnosis to a biomarker-based diagnosis. In addition, because we are looking at biomarkers, we are more specific in terms of our etiology. We know we talk about amyloid and tau, and that is why we are focusing on etiology, and this is more specific for the diagnosis of Alzheimer's disease. We are not just looking at the syndrome of the typical phenotypic presentation. This framework also involves state-of-art diagnostics, and then most interestingly, it lays out a criterion validity for anyone or any scientific group that claims that they are treating Alzheimer's, that the intervention should modify both the biomarkers and the symptoms. You cannot just change one and claim that you're treating Alzheimer's from the disease modifying perspective. So what is biological definition of Alzheimer's? It consists of amyloid, tau, and neurodegeneration. And how do we look at this, or how do we find that someone has this, is by looking at CSF studies and imaging studies. And imaging studies could be either PET or MRI studies. And you don't need both to diagnose or to look at the biomarkers in someone. You can do either or. So for CSF, we look at the amyloid beta 42, the one that we were talking about a few slides ago, or you look at the ratio of amyloid beta 42 over 40. It should be actually lesser in the CSF because this denotes that it's accumulating more in the brain and it's not cleared as well in the CSF. For tau, we are looking at the phosphorylated tau. This biomarker increases in the CSF as you have more and more formation of phosphorylated helical paired tau structures. Neurodegeneration, we look at the CSF total tau, and that is a good indicator for the amount of volumetric loss that is happening in the brain, because you remember how the volumetric loss happens right after the tau is getting deposited in the cells. For the imaging, in terms of the amyloid and tau, we look at the PET studies for both of them. The radio tracer is different, but it is the PET study for amyloid and tau respectively. And then for neurodegeneration, you can just get an MRI, look at the volumetric loss, or you can get an FDG PET and look at the hypometabolism pattern to diagnose or to categorize the neurodegeneration biomarker. So let's look at how we categorize different patterns. So if you have amyloid, if you have tau, and if you have neurodegeneration, well, you got Alzheimer's disease. But what happens if we have none of these? Then we call that person's profile as a normal Alzheimer's disease profile. Let's look at a couple more scenarios here. What if you have amyloid deposition in your brain, but you don't have tau and you don't have neurodegeneration? What will you call this person or this profile? So that's called as Alzheimer's pathologic change. Now that is indicating that the very first step has happened, and it also indicates that Alzheimer's disease is a continuum. So we are saying that the first pathologic change has happened, but we're not calling it Alzheimer's disease yet. And so remember how we talked a while ago about the biomarkers. Amyloid comes first, tau comes second, and that is the whole idea that about the continuum. So we are indicating that we are right here in the continuum. Moving on, what if you have amyloid that's not present in the brain? You're negative for amyloid, but you have both tau and neurodegeneration. So we don't have this, but we have everything beyond this. So what should we call this person, this biomarker profile? So this is called as non-Alzheimer's pathologic change, because a few slides ago, we discussed that for the pathological hallmark of Alzheimer's, you need to have both plaques and tangles. And if you don't have amyloid, then you can't call that person having Alzheimer's disease. And we know that there are other tau pathologies that exist. So that's why we say that probably there's something else going on in the brain, and the tau is driving the neurodegeneration, but it is not Alzheimer's disease because the amyloid is supposed to come first. And it should be positive for us to call it Alzheimer's disease. So we come back to our timeline graph, and as you have noticed, we have only talked about the biomarkers so far. We haven't talked about when a person himself feels subjective cognitive loss or cognitive issues. We haven't talked about where are we in terms of when we administer them tests and when we start diagnosing someone with having an Alzheimer's disease phenotype. So that happens pretty late. This magenta line describes when the individuals will feel that they're having a cognitive loss, and clinically we do very, very poorly because clinical function gets affected in the end. And it's really late if you look at the timeline. So the primary takeaway from this biological construct of Alzheimer's disease is that if you are looking at the classic phenotypic presentation, or if you're looking for clinical signs of the disease, you are always going to play catch up no matter what. You're right here. And by this time, everything is already confluent in the brain. All the biomarkers are there. You've lost your synapses, you've lost your neurons. But if you go by a biomarker-based approach, you are ahead in the game. And so that's why we, when we're talking about disease-modifying therapies, we have to consider the biomarkers. So we have discussed the biological construct of Alzheimer's disease. Let's on to the most exciting section of the talk, the contemporary disease-modifying therapies. So I'll start this with the takeaway that we did in the pathogenesis section, where we said if we need to do something, we need to attack the beta amyloid, because this is the first thing that happens in the disease pathology. It is not as simple because amyloid exists in different species in our brain, and to figure out which one is most neurotoxic and which one to attack has been something that the scientists who are engaged in this research have been figuring out. And to figure out, they have developed drugs for every single step of the beta amyloid plaque formation. And these are the trials that have happened for the drugs that are recently approved. And in terms of the medications that did not work, gantenerumab is one of them, solanezumab is one of them, and then ENGAGE trial for aducanumab also was a negative trial. So for this talk, and in addition, Envision is the trial that they recently withdrew from just 2 weeks ago on January 31st for aducanumab. For this talk, we are going to focus on Clarity AD for lecanemab. We'll look at Emerge trial for aducanumab. That was the positive trial. We'll also look at the PRIME trial for aducanumab. That was the phase 1 trial. And since we are looking at Emerge trial, and ENGAGE was very similar to the Emerge trial, we will also look at the ENGAGE trial, which was a negative trial for the aducanumab. Before we go into looking at the trials, let's do a clinical trials phases 101. So we have 3 phases of clinical trials. The first phase involves 10 individuals. Mostly they are healthy. In phase 2 and 3, we have hundreds to thousands of individuals. Usually these are individuals who have got the disease that you're looking at. Because of that, we also include a placebo group to compare with the therapy. And then in terms of the questions that we are asking, in phase 1, we ask, is this drug safe? We are giving this medication for the very first time to individuals, and we want to figure out if it is safe. And if you notice, as the number of individuals is going up, that will always be a question as more and more individuals are getting exposed to the drug. So is this safe will always be a question in phase 2, but in phase 2, you will also ask, is it effective? Because now I'm giving it to the patients who have the disease, and also I have a placebo group to compare to. In the phase 3, you ask the same question, is it safe? But you also ask, is it better than the standard of care? In addition to looking at the clinical trial phases, it's really important to also look at clinical dementia rating scale before we start looking at all the drug trials information. So clinical dementia rating scale is very similar to the mini mental status exam that we give to our patients. The big difference is that you administer it to the informant as well as the patient, and it takes a little longer because this is more extensive. It has 6 domains: memory, orientation, judgment, community affairs, home and hobbies, and personal care. So once you administer this scale and you evaluate a patient, you give them a global score, just like in MMSE. You can give them a score of 30, 26, however they score. The only difference is it's a little flipped in terms of how you score. So the 0 number is the one that you give to someone who's normal, and anything above 0 is signifying cognitive impairment. So 0.5 stands for mild cognitive impairment, and 1 to 3 stands for mild to severe dementia. So overall, 0 is good, 3 is really bad. And so again, looking at the same scale and looking at the global score that we had looked on the previous slide, they go from 0 to 3, but there is a step in between these two, and that is CDR sum of boxes. And this scale goes from 0 to 18. So you may ask, how is that scored then? So every single domain has a score going from 0 to 3, and there are 6 total domains. So you can have a maximum score of 18 and a minimum score of 0. So in a way, to say this is a little bit more granular approach to look at the clinical dementia rating. And as a result, the CDR global score is often used as the entry point in the trial. So if you have a CDR of 0.5 to 1, you enter the trial as a patient because that's considered as early onset or early in the disease process. And CDR sum of boxes is often looked at as a primary endpoint. And you'll look at all the trials, they include CDR sum of boxes as their primary endpoint to see how patients are doing during the duration of drug administration. So before we leave these slides, just making sure 0 is a good thing and 18 is the bad thing. And the same thing holds true for CDR global score. It's just scored differently from the MMSE. So now let's look at clinical trials. And to look at the different clinical trials, I'm going to use this framework. And we will first ask, what is the primary question that is being pursued by the researchers? Who is the patient population? So what is the inclusion criteria? What was the CDR CDR global score for them when they entered the study? And then how are they studied in the study? So how often they're getting the drugs, and what is the placebo group, all those details. So let's look at the very first trial for aducanumab, phase 1 trial. It was called the PRIME trial. The primary endpoint for this trial, as you remember, we used to ask for the phase 1, is it safe? And so that was the endpoint, safety and tolerability. In this trial, 165 patients were included. So not healthy individuals that we usually do in phase 1, but that's fine. Out of these 165 individuals, 125 got aducanumab. The way the inclusion criteria was clinical diagnosis of mild AD and amyloid beta positivity. So also a confirmation that they do have amyloid in their brain before we start treating the amyloid. These patients got 1 year monthly infusions of aducanumab, and they were divided into groups of placebo, or they were getting any dose group. They were randomized to any dose group from 1 to 10 milligram per kilogram. And since we are looking at safety, it is now time to talk about amyloid-related imaging abnormalities. So this is a strange name because this doesn't only happen to imaging, this happens to individuals, and it can be life-threatening. And what does it entail is it has 2 different varieties. So you can have ARIA-E standing for edema, and you can have ARIA-H standing for hemorrhage. So you may ask, well, why are the individuals who are getting the aducanumab or any other beta amyloid therapy are having these side effects? The reason is that once you have the beta amyloid and once you give them a monoclonal antibody like aducanumab, it tags the beta amyloid plaque strongly. As a result, there is a very robust neuroinflammatory reaction, so it can result in edema. In addition, beta amyloid accumulates not only in the brain parenchyma, it also accumulates in the arteries or in the vessel walls. As a result, if you inflame a vessel wall, it's going to leak, and that's why we see hemorrhages. Now, if you notice, I've used the slide for ApoE here. Why is that? Well, we do see, because ApoE4 had a very strong role in causing neuroinflammation, we do see these side effects happening more strongly or robustly in individuals who have ApoE4 positivity. And we'll look at it in the next slide. So here is the safety and tolerability data from the phase 1 trial for aducanumab. On the top here, you'll see the dosages of aducanumab going from 1 to 10 milligram per kilogram. And bottom here, you'll see ARIA-E, ARIA edema, ARIA-H, ARIA hemorrhage, and they are segregated by ApoE4 and the individuals who had either E2 or E3 variant. So what did we see? So these numbers are in percentages, and you can notice here for the dosages 1 and 3, the degree of side effects was maybe the highest as 9%. But if you look here at 6 and 10 milligram per kilogram, we had substantial individuals who got ARIA-E. So 55%, more than half of the individuals who had ApoE4 positivity had the ARIA reaction. And so is the case with 6 mg per kg, very high percentage of having the side effect. Of course, if you are not having the ApoE4 positivity, the incidence of the side effect was lower as compared to the individuals who had ApoE4 positivity. So that's something that all these trials also look into when they randomize individuals who are getting higher or lower dosages of aducanumab. So we are also interested in looking at what did it do to the beta amyloid in the brain. We found out that, yeah, maybe the lower dosages are safer and the higher dosages are not as safe for individuals, especially if you have ApoE4 positivity. What did it do to the individual's brain? So here are PET amyloid scans, and this region here, the red region, indicates the beta amyloid deposition in the brain. So for patients, let's see what the aducanumab did to their brain. So you can see for placebo, no difference, but it did remove beta amyloid from the brain in a dose-dependent manner. Higher the dose, more the removal of the beta amyloid. That was pretty encouraging. So we move on to ENGAGE and EMERGE trials. Now, aducanumab did not have a phase 2 trial. It went straight from phase 1 to phase 3. Here, the primary endpoint is the CDR sum of boxes, the same scale that goes from 0 to 18. And the secondary endpoints was, of course, they were looking at how good it was removing the beta amyloid from the PET. And then there are other two cognitive scales. Inclusion criteria was clinically mild Alzheimer's disease and PET amyloid positivity. CDR score was 0.5. That was the global score, the entry point in the trial. But the primary endpoint is your CDR sum of boxes that goes from 0 to 18. They had thousands of patients, total about 3,000 patients in both the studies. Patients were randomized in 3 groups, so placebo, 6 mg per kg, and 10 mg per kg. So not the lower doses of 1 and 3, rather the higher doses of 6 mg per kg and 10 mg per kg, which were associated with side effects. The study was done for 18 months. Here, I do want you to focus your high attention to the fact that the primary endpoint is cognition and not beta amyloid. And you may say, if you were the designer of the study, you would rather put this as a primary endpoint because we had very encouraging results from the PRIME trial. Why did they make this a secondary endpoint and cognition the prime point? The reason is we have had about 20 drugs that remove beta amyloid from the brain very well, but they don't affect cognition at all. So currently we are looking at something that will improve the cognition and not just the beta amyloid. So this is the ENGAGE trial results. These are the results that are positive. To orient ourselves, on the y-axis is the CDR sum of boxes, and we are looking at the change. So remember how the scale went from 0 to 18, but here it's only going from 0 to 2? The reason is we are just looking at the change from the entry point to the end of the study, to the end of the 18 months. So if you entered at 15, did you go up to 17 is what we are looking at. So there are 3 lines. The top line is for placebo, and then we have the low dose and the high dose. So, and on the y-axis, of course, there is time in weeks. So what are we seeing here is that if you did not get anything, or if you were in the placebo group, you will have progression in your cognitive decline as your CDR sum of boxes score is going up. But if you are having a high dose, the decline will be slower, and it is significant. For the ENGAGE trial, these differences were not significant. Let's closely look at these numbers and figure out how significant are the results. So if you were following the news or the media at that time aducanumab was approved, they were talking about this number 22% a lot. This is a drug that slows cognitive decline by 22%. This is huge for Alzheimer's disease. So I was curious, well, how did you get that number for CDR sum of boxes? So the way they got this number was CDR sum of boxes for placebo was 1.74. This basically means if you entered the study at number 15, at the end of 8 months, you did decline and your score was 15.74 on a scale that goes from 0 to 18. But if you got the high dose monthly infusions of aducanumab, the 10 milligram per kilogram, you declined slower. So you increased by just 1.35. So if you entered at 15, you were 16.35. So that is a small difference. But the way it's calculated, the percentages are magnified. And when I found this, my head was blown because this is a scale that goes from 0 to 18, and you are just looking at the differences and you're magnifying the results. And to get a better sense of that, let's look at MMSE. This is something we all administer in our clinics. Imagine you gave someone a high dose of the medication and risked them for developing ARIA-E or H. And at the end, they were not different from the placebo group, not even by 0.6, that's all. So when you look at it that way, it's not a lot. In percentages, it seems a lot. Lecanemab trial was very similar to the EMERGE and ENGAGE trial for aducanumab. The only differences are highlighted in green here. So we had one more cognitive skill. We had tau and MRI data that they haven't released yet. We also had CSF criteria in addition to the PET, so you could do either one of these. And the patients were randomized in one or in placebo or 10 mg per kg group. Again, the primary endpoint is cognition. We are not so interested in the beta amyloid removal. So what happened in lecanemab Clarity AD trial? They have inversed the scale. So instead of doing 0 to 2, they are just doing it 0 to 2 like this. And so what you see here is for CDR sum of boxes, people who got lecanemab declined slower as compared to placebo. How slow were they? By 27%. Again, if you were following the media at that time, this number was thrown around a lot. And how did they calculate it? So the CDR sum of boxes declined, or the number increased for placebo group by 1.66, and it increased by 1.21 for lecanemab, and it's calculated in a very similar way as was aducanumab. So again, the results were magnified. The other thing that comes with these cognitive scales, and specifically CDR sum of boxes, are some issues in the way you are interpreting the data. And this is an analogy that Dr. Benj had used to explain it to me. And so I'm borrowing this analogy from him. And the reason I'm using an MRS scale, a motor scale, to make my point is because it's easier to imagine motor issues as compared to cognitive issues. So on this scale, if you go from 3 to 4, you need assistance to walk. But if you go from 5 to 6, you're dead from being alive. Now, that is not a linear scale. This is a logarithmic scale. And so you cannot just subtract the numbers on the scale and expect that the results will be making sense that way. So the reason is the difference between two score levels is not the same as we just looked at it right now. And then continuous variables, although we assign numbers to them, you cannot subtract them. That's a strange thing to do. In addition, there are 6 categories on CDR. Where did this person decline? Was it home and hobbies? That's fine. I mean, if I would lose more points from personal care, that means a lot for the quality of life. So they didn't look at where the points were lost. We just looked at, oh, this is the number, but we don't know where the points were lost. In addition, we always look at, whenever we are looking at a paper, we look at, is this difference between two comparison groups significant? In addition to that, we also have to ask a question, minimally clinically significant difference. So these two words are extra here. This is a concept that comes from the fact that this is a cognitive issue, and we have to hear what was the patient's impression of the intervention. So we look at the magnitude, but we also ask patients, is this valuable to you? Is this change of whatever number it is it really causing a meaningful change in your life? And so guess what CDR sum of boxes minimum changes? It's 1, and it's preferable to be 1 to 2. What was for aducanumab in the study emerge trial? It was just 0.39, so it's less than 1. The number for lecanemab was 0.45, so it was also less than 1. So it's not minimally clinically significant difference. So we have met the third objective as well. Now, based on that, the conclusion is amyloid beta therapies do not slow cognition safely and in a clinically significant quantity. And this would be a strange place to end the talk, because you'll always wonder, why is that? What happened? Why are we attacked the right biomarker? How come we're not getting the solution that we wanted? And so those of who know me know that I've been pursuing this question for the past couple years, and we presented our results at AN the last year, and we studied a group. We looked at a data set, OASIS, and this study included about 1,000 individuals. 755 of these were cognitively unimpaired, and then we also looked at individuals who had mild cognitive impairment, so 0.5 of CDR. These individuals were looked at 15 years longitudinally, and they got brain scans looking at the beta amyloid every 1 to 3 years, and they also got all the neuropsychological testing done for themselves every 1 to 3 years. And what did we find with this? And how does that answer the question why we are not there yet? So we found that by the time you're diagnosing someone with MCI, amyloid beta is confluent in your brain. So this is a correlation graph. Here you can see 200 brain regions stacked on top of each other. And then on the bottom, you see there are two global cognitive scales. And so these are individuals who are having a CDR of 0.5. That's when you enter in the studies. And this is the amyloid PET data. So we are looking at the beta amyloid deposition, and we're looking at the correlation between that, the beta amyloid deposition, and this global cognitive scales. And what do we see here? We see that this is for CDR. So higher the number on CDR, so more severe the cognitive impairment, more is the beta amyloid, and it's positive throughout the brain. It's not just one brain region that's lighting up, it's throughout the brain. And MMSE, the scale is reversed because it's scored inversely. This holds true for all neuropsychological tests that are given to individuals as a uniform set that we administer to individuals with Alzheimer's disease. And all these relationships are significant. They are corrected for multiple comparisons. So this was something that was very surprising. But you may ask, well, yeah, that was a graph. How does that look on the brain? So this is how it looks on the brain. This is a difference map. So this highlights how your brain is different. So how a normal individual's brain is different from someone who has a mild cognitive impairment diagnosis. And this is looking at the beta amyloid deposition in the brain. These are, again, all individuals who have a CDR score of 0.5. So mild cognitive impairment, beta amyloid imaging, MNI sagittal sections of the brain. Where is the beta amyloid the most? So it is these bright yellow sections. So you can see here, basal regions of the brain, the frontal cortex, the parietal cortex has confluent beta amyloid when the individuals get a diagnosis of MCI and when they enter the studies. In addition, we also did cluster analysis. So this is an analysis where you just look at the data and you ask the question, are there any naturally forming clusters in the data? And what we found was that there were two clusters in the data. And then you overlay your labels and say, oh, okay, where are the individuals? Are they clustering in a meaningful way? And what we found was that individuals who had cognitive impairment were clustering in the dark gray region, but individuals who are normal, so these red dots, they don't cluster. So they don't really segregate as a separate group. And that's really strange because these individuals are cognitively normal despite the fact that they have confluent amyloid beta in their brain, which is really strange. And some unlucky individuals here do segregate, and they do have, they do form a cluster, and they do show the effects of amyloid beta in the brain. So again, coming back to the question, why don't amyloid beta therapies work? The reason is, even though when we started at amyloid beta accumulation, the very first point in the pathogenesis, amyloid beta is confluent. By the time individuals enter in the studies, by the time their CDR score is 0.5, and that's what we found. And in addition, if you can look at this graph again, if you are taking individuals from here, we're not really here, we are here. So that's where the beta amyloid is. It's all over the brain, it's already plateauing. And your tau is also in a significant quantity in the brain. We also have limitations in the biomarker detection. So there is a little bit of buildup of amyloid before we can detect it, as we had talked about in the initial slides. And then there's this temporal lag. So if you have something that's abnormal and it's neurotoxic, your innate immunity is going to react within minutes to hours. It's not going to wait for years. And we are removing the amyloid years after it's been deposited. So the downstream steps have already taken place by the time you're removing the beta amyloid from the brain. And as we know, in addition from losing synapse from beta amyloid, we also have tau pathogenesis that starts after a buildup of amyloid, and this is a synergistic pathway. So this is a vicious cycle. Once it starts, it's you're already there. In addition, we do have a poor understanding of pathogenesis, And this is something we realized when we saw that the normal individuals here in the red dots really don't cluster. And we don't know what's the tipping point for some individuals to have confluent beta amyloid and just be normal cognitively, and for some individuals to develop the whole pathology of Alzheimer's disease. So we really don't know what is happening to tip some people over into disease and some people being normal. So that is all. I want to thank Dr. Kumar, who was my co-PI in the study and gave me wonderful feedback for this talk after we had multiple iterations of the talk. And this is the Dream Lake in Colorado. It's my favorite lake. This was really wonderful. It's a topic that I find very close to my heart. So I enjoyed talking to you guys. I'm happy to take any questions.
All right. Thank you so much, Dr. Verma. We actually have a question in the room, and then I'll address the questions in the chat.
Hello, Khushboo. Such a great talk. I really appreciate it. This is obviously dear to my heart too. And you did a wonderful, excellent job of summarizing the disease pathology and some of the controversy that surrounds the new disease-modifying therapies. There was a recent editorial too that came out sort of questioning the sum of boxes thing that you were talking about and really questioning their calculation of the score. And it brought up another thing that I had not been aware of, and I'm curious if you had looked into. Deep within the appendices of the report on lecanemab were the gender breakdown and the ApoE4 breakdown of people who responded and didn't respond. And as well as looking at, when you look at the sum of boxes and you just look at the memory component, there was an improvement, but it was really small. So it was like less than 9%. And it turns out that women in this study, there was no mention of male, female, women, gender in the entire lecanemab report that came out. But when you look in the appendices, you break it down, and it looks like women actually did not have a benefit at all. And yet they're twice as likely to get Alzheimer's. So it called into question a lot more of these things. And the ApoE4 group actually did better in the placebo group in terms of cognitive improvement and some of box's cognitive improvement. I'm curious if you had looked into that and the gender breakdown as well as the ApoE4 breakdown on the disease-modifying therapies, if you had come across those. It was a point of our conversation in a recent morning report about an ARIA patient we had.
Oh, okay. Yeah, I mean, if you look at the data for all these studies, they don't involve a diverse ethnic backgrounds. It's primarily Caucasian individuals. So that's something that's come in. And if you look closely at Emerge trial, which was positive, and Engage that was negative, Emerge trial had 3 modifications in their protocol, and they randomized more individuals who had ApoE4 to get the higher dose. So they put people at risk to get the ARIA side effect knowingly. And these were also modifications done after they had some data analysis done. So I'm not sure how that was approved and how can you start randomizing individuals once you've done a little bit of the study. And that's the major difference between Emerge and Engage in how they change some subjects randomization after a little bit of data analysis. And that's the big reason of the difference between the studies.
And I know we have a lot of questions on it. We're right at time, but I'll go ahead and maybe have you read through a couple of the questions.
Yeah. Okay. So,
quick answers.
Dr. Ong asks, since AD is diagnosed by having both plaques and tangles, why is amyloid plaque formation only still referred to as Alzheimer's pathologic changes? Is it referred to Alzheimer's pathologic changes even without neurodegeneration by having only plaques?
So it is a part of Alzheimer's disease, and we are basically saying that you have entered the Alzheimer's continuum, and we are calling it Alzheimer's pathologic change, suggesting that we are likely to develop the subsequent steps in the pathology.
Okay. Dr. Logue asks, can you comment on polygenetic risk for AD versus APOE alone? Is there any evidence that using a PRS that includes APOE is superior to using APOE alone, or that even PRS without APOE is relevant in some cases? Because some people get AD without the APOE4 or a mutation, and although environmental factors are at play, I also wonder about genetics beyond APOE4.
Yeah. that is something that I myself have to look into and learn more about the polygenetic risk factors in terms of, that's where we do not know about what tips some individuals to get Alzheimer's disease. So that's something that I don't know yet. I have to learn about it.
All right. And Dr. Pedafar says, excellent review, Dr. Verma. Please comment on the failure of the anti-amyloid vaccines and whether there are new approaches for vaccination that are promising. For example, vaccinating high-risk individuals in the asymptomatic phase and long before the pathology starts.
Yes, again, that goes back to the fact that we are kind of coming across in the talk, by the end of the talk, the fact that we do not know what if beta amyloid itself is sufficient to cause the disease. So, calling into question amyloid beta hypothesis by itself, it is the first step, but we don't have a great understanding of why some individuals are getting Alzheimer's and why others are not. And so it's really tricky, to administer medications when you don't know if 30 years down the line you're going to develop cognitive symptoms or not. And that's why we are in a difficult spot in terms of vaccines and medications.
All right, that was the last question in the chat, and there are a couple nice comments in there for you to read, but we're a little bit past time, so thank you all for joining us, and we'll see you again next week.
Awesome.